Well, hello, everyone, and welcome to our weekly Wound Care Pro series with Nurse Practitioner Anne Walsh. Nurse Practitioner Anne Walsh is the founder of Wound Care Pro. If you are a physician, clinician, or even a patient that has questions about the guidelines for wound care, especially when it comes to those diabetic wounds, bed sores, and malignant wounds that we're going to be talking about today, make sure you do download Wound Care Pro from the App Store or Google Play. Welcome, Nurse Practitioner Anne. We really appreciate you being here again and donating your time and helping to educate physicians, clinicians, and patients alike.
Thank you. Great to be here again.
So, why are we talking about malignant wounds?
Well, I mean, I see a lot of them in my practice, and I think sometimes if somebody doesn't know what they're looking for, they may not even get treatment early on. If somebody has a wound that just seems to be sitting there, it's not healing, and maybe it's getting bigger, it's bleeding, it's tender to the touch or something like that, and just slapping a Band-Aid on it and not getting it looked at, it prompts us. So I think it's a good reminder just a wound like that should be healing, that's not, to get it checked by a dermatologist or your healthcare provider.
We focus here through the Global PAD Association with ulcers related to lack of circulation. What are some of the key visual characteristics of circulation related or diabetic ulcers and malignant wounds?
Yeah, so the diabetic foot ulcers typically are the bottom of the foot. As the person's walking and putting a stress on a particular area of the foot, they may not feel that they're doing that because of neuropathy. And it may start off as a callus, just from the wear and tear, and then ulcerate. So that's typically what we'll find in somebody with diabetes and peripheral neuropathy. There's arterial ulcers from poor circulation getting to the foot, maybe on the toes or the heel or other parts of the foot. You may see an ulcer that develops due to maybe rubbing against a shoe, and then poor circulation contributes, and then you have a wound like that. Whereas the venous leg ulcers typically is on the ankle area. Person may have edema, and somebody might have all the above. But whereas a wound that's due to malignancy may be bleeding easily, and again, it may not, be sitting there not healing at all. There may be an odor, and it might have like a strange appearance to it. Like we call it like cauliflower-like, if it's sort of growing outward. So that's something to keep an eye on and get checked when you're unsure.
So, where are cancerous ulcers most likely to develop? Can they develop anywhere?
Pretty much anywhere, yeah. I mean, if it's due to sun exposure, like squamous cell carcinoma or basal cell, then you might see those more on the head, the face, the arms, from sun exposure. If it's a malignant wound due to, let's say, breast cancer, then you may have on the
Mhm.
breast, chest area. But basically, any wound technically could, metastasize to the skin, and you may have a malignant wound. But we see a lot of times head and neck cancers, and breast cancers are a big one.
What are the different stages of malignant wounds and how do they progress?
I mean, if they're caught early, they're very treatable, that the skin cancers like basal cell and squamous cell. Other wounds that may develop from advanced cancer as the cancer is progressing, then they're more advanced. Let's say if somebody has stage 4 breast cancer, and then they may all of a sudden, or been developing a wound on the breast. I've had a patient one time just sort of ignored it for a long time. She was elderly and she didn't want to bother the family, and she just sort of went along. And then as she became older and more frail and they were caring for her, like, oh my God, what's going on? Why is there blood on her shirt? And it turned out this wound is progressing over time. Had she got treatment for it earlier, perhaps, things could have been done. But at this stage, it was the size of a, football, basically, over time had been growing and growing, then bleeding. And at this point, she had dementia, so she didn't even know what was going on, sort of. She was pleasantly confused, and it's a shame. So we've heard those kinds of stories, or somebody had a little something on their face, they ignored it, and then by the time it's healthcare providers get involved, it's way advanced.
Are they pretty slow moving or growing, or are they fast growing for the most part?
Pretty fast growing, depending what kind of cancer. If it's basal cell or squamous cell from sun exposure, they don't grow too rapidly, so they could be, taken care of. But if they're let go over time, for extended period of time, it could be a problem. Other cancers, and that's a way we know a wound may be cancerous. If you see all of a sudden this wound seems to be growing rather fast compared to another type of a wound, that's a clue that there could be a malignancy here, and we need it biopsied to determine that.
Is there a certain type of person that is most at risk of these malignant wounds?
Well, yeah, I mean, as far as skin exposure to the sun, if somebody's like more fair skinned, um, if you have a weakened immune system, you're more prone to getting these kinds of cancers. If you already have another kind of cancer, you're more prone to it metastasizing to the skin. If somebody's on immunosuppressants, so their immune system is suppressed. Also, if somebody has an injury to the skin, a burn, let's say, for example, they could actually, scar tissue from a burn or its repeated injury could actually turn malignant. They call it marjolin, Marjolin, ulcer. So it's a chronic wound or chronic injury, like I say, a burn or other wound that's been around a while could actually become malignant.
So how does I can imagine, I mean, of course, this is almost rhetorical, but obviously that there is a difference in treatment approach in the early stage malignant wounds compared to most advanced stages, right? Would you mind walking us through some of the different treatments that might occur early on versus later stage?
Sure, yeah. So if it's caught early, let's say if you have a wound on your leg and you're assuming it's, a vascular wound, but it's not really responding to typical treatment, and you get it biopsied, then there's treatment options available if it's earlier on, like topical chemotherapies, let's say. It could be a surgical intervention, um, radiation, perhaps, depending on the situation, or even medications you could take to, immunotherapy, for example. So there are options available. Where if it's later stages and the wound has no, option of healing, poor healing potential, then we switch gears and say, okay, what's bothering the person? Is it pain? We'll treat the pain. Is the wound bleeding? Lots of options for controlling the bleeding. If there's an odor, and a lot of drainage, there's dressings we could use, manage drainage, manage the odor. Again, the pain, sometimes people get itching around, it drives them crazy. So we use certain creams for that. So it's sort of taking an approach of how can we manage your distressing symptoms versus expecting this to heal.
You mentioned, quite a few symptoms that come along with these wounds that you would suspect um, infection. So I'm curious, are these malignant wounds typically infected or simply at risk of becoming infected? And so the key is to prevent infection.
Yeah, they're at risk
What
of
does it look
becoming
like?
infected, as the cancer's proliferating and, some necrotic tissue there, the bacteria is like feeding on that and fungal overgrowth. So sometimes if we're getting an odor, we could order dressings that'll have, let's say, silver in them or the honey products, try to treat a superficial infection. If it's more pronounced, let's say there's redness all around and the area is swollen, extra painful, then the person may need systemic antibiotics to manage that.
So what are the signs that indicate that a malignant wound may be too advanced for curative treatment?
As it's growing and the patient has metastasized, the cancer has metastasized to other parts of the body, then it's the overall picture is not good. If the person has advanced, let's say stage 4 breast cancer, and they have a wound that's growing, most likely we have to switch gears and take a palliative approach to manage the symptoms.
Yeah, and when you're managing a patient's quality of life in these cases, what does that look like?
Yeah, so we meet with the patient, the family, and just see what's bothering them and what are their goals of care at this stage. And they'll oftentimes tell us, "Oh my God, this thing is bleeding. What can you do for that?" And sometimes it might be simply that they're taking aspirin or they're taking anticoagulants, and then you find out they were just in the hospital last week due to bleeding. So, okay, let's stop this. At this point, it's more of harm to you than any benefit. And then if that's not, alone working. We even do things like, oxymetazoline, it's Afrin spray for the nose. Believe it or not, we could spray that to a wound to help vasoconstrict the tissue and help the bleeding. So a lot of tricks of the trade, or silver nitrate sticks to try to stop the bleeding. And there are dressings available, like the calcium alginates, will manage the drainage, and they're hemostatic, help the bleeding. So just, taking a different approach of what's going on with the person and their family and treating that.
What are some tips and tricks for communicating effectively with the patient and the family on treatment options and the prognosis for patients with malignant wounds?
Yeah, so it takes a whole team. I mean, you want the social workers involved, spiritual care, and the whole medical group. So all of us approaching the patient where they are, what they understand. Because sometimes somebody like, oh, don't tell them, and the person says, I know. A lot of times they know themselves what's going on. Everyone's sort of tiptoeing around. So having family meetings are important, so everyone can sort of be on the same page and open discussion, so that the person can see what's important to them, and we could all, as a team, help them.
It's probably really important to also understand for these patients the key factors in assessing the actual prognosis of a patient with a cancerous ulcer.
Yes, absolutely. A lot of times we're looking at functional status. If the patient, 2 weeks ago they were walking around, now they're bedbound, they're weak, they're sleeping more, they're eating less. These are all things that are clues to that the person may be in the latter stages. You start seeing big changes, like I said, performance status is a big one. And nutrition and even like the kidneys may be slowing down, so not urinating as much. So there's a lot of discussion we have with the family and the patient about what to watch out for, and 24 hours they can call us to help along the way.
And we have a question coming in from Jean. Jean, go ahead and unmute and ask Nurse Practitioner Anne Walsh your question. I can help you with that. There you go.
No, yeah.
There he goes.
I was in a an explosion with some chemicals and burnt my whole body up from the waist up. And I'm having trouble with my left arm constantly. If I do anything lifting heavy or anything like that, one of the scars, and I don't have very many scars, thank God, but one of the scars opens up and it leaks out this jelly-like stuff. And I've had a couple skin grafts and they biopsied and all that, but they haven't told me what to do in the future. But it happens about every 6 months. It'll open up and it'll stay bleeding and all that stuff for about 2 months, 3 months maybe. Should I be real concerned about that?
So you said they biopsied the area?
They did.
Oh,
Yes.
okay. All right. So that's good. Yeah. I mean, you probably want to use a dressing that's not going to stick. Like we use a lot of the zero forms or Vaseline.
I have lots of
Yeah,
zero form. Yeah.
yeah, that's usually
With
because
lots.
you want something that you don't have to change so frequently every time you're pulling off the dressing, and plus
Right.
something that's not going to stick. But yeah, to keep an eye if you're noticing it's bleeding more, or things are changing, any kind of odor, then definitely reach out to your
Yeah. There's
healthcare
an
team.
odor. It just really happens. I mean, there's an odor about every 3 or 4 days comes from it. So I really cleans it with some wound cleaner. But it really only happens when I lift something or do something with my left arm, use it, then it leaks out this like jelly stuff, and they have no idea what it is. Um, I
It
inhaled
might
a
be
lot of
time
this
for
crap.
a second opinion.
Yeah, I've had them. Yeah.
Is there swelling in the
Well,
area that it's fluid buildup or anything? Or
no,
oh, okay.
no, not it. And it's the only scar I've got from the whole thing. I've got discolored skin and all that. So they really did good with me because I was black from my waist up. But
Yeah.
I'm just
Wow.
concerned about this spot.
So
Excuse
do you
me.
get follow up rather frequently?
I went through the burn clinic for 2 years.
Okay.
Yeah. And unfortunately, it was a workers' comp thing. So, I've been dropped off from that now. I've been released, and the burn clinic's released me. And, my PCP I don't see her that often, to be honest. So I don't really have a wound doctor, so to say.
Yeah, follow up would be important just to make sure there's no, infection there causing the bleeding and irritation. And of course that there's no
Yeah. And when it festers up, what I call it. But when it does that, it's just all over my body.
wow.
And, I refuse to take hydroxyzine or anything. I don't take anything that won't let me be aware of what I'm doing. God knows what I'll do then.
Yeah.
And, I'm just kind of concerned about it.
Yeah, and if
So,
you're concerned as nurse practitioner Anne was saying that, it's not possible for every single doctor, every single clinician to know everything. And so you might need not only a second opinion, you might need a third or fourth until we find
right.
you someone that has experience with this and who might have had another patient that had this happen to them and was able to go, oh, wait a minute, I know it worked for them. Here, this might be something that will work for you. And it might not be just typical textbook. It might have been trial and error with someone else that they discovered what might work. So it is worth exploring a few more options. And I know it gets so tiring, when you're in the medical system and you're constantly going to appointments, to then keep fighting and going through the phone trees to get yet another referral and then yet another appointment. And it's a lot.
Yeah.
So
Yeah.
it's worth it if you can find a solution.
All right. Well, thank you very much.
Absolutely,
Of
Jean.
course.
Thanks for asking.
And Kim, go ahead and unmute. Kim, ask your question of Nurse Practitioner Anne Walsh.
Hi there. I was just wondering, do skin cancers usually have a specific color to them?
Well, it depends. Melanoma is usually kind of darkish color. If somebody has a mole, or something like that, if it starts changing shape, they always say the A, B, C, D's, E actually too. So A is like is asymmetry, so it's not even the way it's shaped. And then B is for borders. It's not like a smooth border. It's sort of blurred borders are sort of irregular. C is color. It's not like an even color. It could be a little brownish, blackish, bluish. And D is diameter. So it's just usually bigger than, the size of a eraser on a pencil, usually a little bigger than that. And E is for evolving. So it's just, it's changing. Something's changing. And that's the signs of a melanoma. So you want to get that checked because it's treatable if it's caught early as well.
How often
Squamous cell
should
might
you
be
get
more of like a
checked?
patch, like a pinkish, reddish, irritated, itchy patch on your skin, sort of. And the basal cell is sort of, almost like a bubble. It's like raised and like a nodule of sorts.
How often should you get checked? I know my parents would always go every 6 months, and they had standing appointments every 6 months to have a dermatologist go head to toe.
Yeah, I mean, me, myself, my dermatologist come once a year, and they would say after the summer, I guess, because, they want to see how things are looking after any kind of sun exposure. So it would depend on the person, I guess. If you're more at risk and maybe you have a skin cancer that was removed, they may want to see you sooner, maybe every couple of, 6 months or so, depending on the situation.
Does having any sort of, chronic illness, inflammatory illness, increase your risk of these malignant wounds?
Yeah, I mean, if your immune system's compromised, or you're on medications that are, suppressing your immune system, you're certainly more at risk for getting some kind of skin cancer.
Thank you so much, Nurse Practitioner Anne Walsh. Did we miss anything when it comes to malignant wounds that you think are really important for people to know?
Just, yeah, if you have a wound that's not healing, and it, maybe on your arms, your legs, and your scalp or whatever, and it's bleeding, and it seems to be, something strange with it, and it may close up and open up again. I had a friend recently, he said, I had this wound on my leg, and it was small. So he was, a big tough guy. He's like that. And it closed and it opened up again and it was bleeding. And he said, this thing is bleeding so much, it's so small. He went and got biopsied, and sure enough, it was skin cancer. So just catching them early, because they are very treatable, rather than waiting and, over time, that this thing could fester and, cause more distress for you, pain and not be self-treatable.
Definitely. Well, thank you so much, Nurse Practitioner Anne Walsh. We appreciate you coming every single week, donating your time and educating us, as well as other patients, clinicians, and physicians on, wound care on such a variety of different topics. Make sure that if you want to see more with Nurse Practitioner Anne Walsh and our Wound Care Pro series, it's every Wednesday. And you can go to our YouTube channel, youtube.com/The Way to My Heart. Make sure you like this video, make sure you subscribe, and check out our live tab, because underneath we've already gone ahead and we have programmed in the next 2 episodes of the Wound Care Pro. So you'll know what's coming up, and you can actually click on that live video promotion and click on notify me, and it'll notify you to make sure that you don't miss a step with Wound Care Pro. And I can't remember, what are we doing next week? Maybe
Next week we're doing rashes, different rashes we may come across as we age and just in general.
shingles to cellulitis, and of course, just the common rash and the allergic rash. So we're going to dive into that next week. So make sure, again, go to youtube.com/The Way to My Heart. Also, don't forget to download Wound Care Pro. It's available on both Google Play as well as the in the App Store for the iPhone. Okay. Well, I hope everyone has a great week. Big thank you to Nurse Practitioner Anne Walsh, and I hope you have a great rest of your week.